Hello, everyone. Good morning.
Good morning.
Good morning.
Morning, Mildred.
Good morning. Sorry for the late start. I just needed to make sure everyone who is supposed to be here is here before we start. It's not going to be a very long session as we just discuss the surveillance part of the system. So my name is Mildred.
Oh,
Hello.
sorry. Hi, Mildred. This is Ambrose, pharmacist. I'm on Hill page because I cannot sign in on with my phone, so we're good together today.
Okay.
All right.
All right. So we are going to look at the reporting part of the system, and we're going to see how the system generates reports from all of the data that we have entered so far. First of all, let's just look at the run through of what the system is and how we got to this point. So the case-based surveillance system has 3 modules. We talked about the administration module, which just deals with all of the functionalities of the configuration and account setups and how to retrieve lost accounts and manage accounts and both clients and users accounts. And then we looked at the screenings and management module that deals with all of the data collection from screenings to management, prescription, and everything that happens from when the client is screened until death. And we also look at the clinical management of other STIs and also the registration of exposed infants and the care and management. Then we looked at antenatal screenings and antenatal clients also. In that part of the system, the screenings and management part, there's a lot of information collected. All the information collected from each form is important. They're important to be complete, especially the behavioral information about the client and also the screenings results and all of the dates that are involved. It's also important to have at least the year of birth of the client also. This way the system knows what values to pick and generates the report. So assuming that your data on the system is complete, the very day you are supposed to submit your report, you can wake up on that day and go to the system and just download it without any additional work or calculation to be done. So once you log in as a user assigned the monitoring and reporting role, you will have access to different functionalities based on your permissions. Now, most of the time for reports, you can give all 4 permissions. The person will have the screenings, prevention, and control reports drop-down menu, this commitments to 90 target drop-down menu, the antenatal reporting, and the pharmacy reports drop-down menus. Now we have minimal data on this system that we use for the training, but we are going to look at how all of the practice we've been doing on it, what the data looks like, and how the system prevents. So the first entry point of the system is creating a client account. When those accounts are created, we have basic information like their year of birth, their biological sex. And then when we collect other personal information, we get information about their gender identities and all of their sexual behaviors. When you expand this menu, you have registered client report. This only gives you statistics of all of the number of unique clients on the system, the accounts created in the reporting year. You can look at the sex ratio of the accounts created. This has nothing to do with the diseases that are screened, but the number of clients you have on the system, whether positive, negative, or regardless of what they are screened for. It just gives you those calculations, and you want to see every month how many new clients were registered on the system. You want to look at the sex versus the gender identity of all of these clients, and then you can export this thing in tables as the figures. And so when you give this permission to someone in IT or surveillance that are not supposed to look at the client record, it's safe because it only gives figures. It does not report anything about any individual person and does not expose any record about anybody, but just calculates and aggregates or disaggregates figures and presents them. Then you want to move to HIV screenings and positivity reports. Now, depending on what reports you want to extract, you can come there, select a year. It gives you everything about that year and give you different months of the year and the different things. Now, when you read all of this, it tells you the total number of people that were screened for HIV, including the pregnant women and those excluding pregnant women, the total number of males screened, the total number of female that are screened and positive, and the total number of those that are positive excluding pregnant. You'll find the total number of intersex and all of those values, and then it calculates the screenings per 100,000 population. So recall that when we looked at the administration module, we talked about entering the census record for the country. Now, this reporting part takes that census information that is equal to the selected year or less than the selected year, but not the most recent relative to the selected year here, and calculates these screenings and positives per 100,000 population. Then you can see the sex ratio of those screened for HIV, and then the sex ratio of those positive for HIV. Then we can see the 10-year trend in positive. Now, because we just use this system for this training, all our information is just for this year. But assuming you go to your live system that you have records from several years, you will see the trends in the screening for the last 10 years. Then you have the screenings per month. You will see the different months of the screenings and screenings per age group and sex. So it's still color coded, even though it's by age group. You can see that the blue is for male, female, and intersex, and you can easily get the total number here. Visualizations can also be exported. The figures can also be exported if you want to create different type of visualizations. It gives this visualize the new positive summary, gives the summary of positivity visualized according to the sex, and then the positives by age group and sex. We have the positive per 100,000 population, and then we look at the biological sex versus the gender identity of those that are positive, and the 10-year trend in new positive. Then we look at the screenings by the testing modality, and then we look at the positivity by testing modality. Then you can look at this table now to be able to export in Excel, PDF, print. All of those information that we have in this charts are all in tables here for you to export in your spreadsheet. So this is easier to export than going to the database and getting raw data and trying to aggregate them or disaggregate them. This does the calculation and gives you the total numbers. So it was from this figure that the visualizations were automatically created. Now we have HIV statistics by ethnicity also. So assuming you fill the personal information completely and you have the ethnicity, you can now see the total number of people screened for each ethnicity. You can also get the positives for the different ethnicities for the record you have entered. So we have the same thing for syphilis screenings and positivity. It's exactly the same tabs as the HIV. This captures the syphilis also the same way, the same tabs, the summary, the trend, and the tables to export, and then that's by ethnicities. So you can look at the positive summary, you can look at the sex ratio and everything. Then we'll have exactly the same thing for tuberculosis. So for this system, and several people have asked that can we select a date range from a particular date to a particular date? No, the system already calculates it. If you select a year, it gives you everything per month, January, February, March. So if your range is January to March, just take the figures from January to March. And the reason for this is if we have that range of dates, the figures based on the amount of dirty records that are entered sometimes we have people enter the current date instead of the date of birth of the person, and we have those kind of errors, and a significant number of records like that. So in order to keep the record accurate, it is better to do per year, and then you get the accurate figure per year. And then when you start looking per month, it is more accurate than when we begin to select range of dates, and then all of the wrong entries begin to factor in. And so that's the reason why you have it select the year, and you get all the information about that year. And if you just want information about a particular month, you can also get it by clicking on the tab that gives you per month here. Okay. So we get the new screening summary for TB, exactly the same as the HIV. Sex ratio, the ratio of positives, also the 10-year trend in the screenings per month. Now, if you take a look at the tabs, they are named or labeled according to the reports that you are going to get from them. Then you also have the behavioral reports. Now, there is this OECS M&E summary sheet that you always fill, right? So that sheet has been coded here so that you don't need to fill the sheet, but you can just export the sheets with the figures already filled in from the system. Now, when you click on this and select the year, you get several tabs. The first one is where you get all the information about key populations. Now you get the total number of male that have sex with male, the total number of transgender male, transgender female, homosexuals, bisexual, transsexuals, and homeless, incarcerated, people that injection drug users, people that use illicit drugs, sex workers. You get this for everybody that was screened. And then you get other risk behaviors also, like those who have been victims of sexual assault, those who have been received a transfusion and all of that, to see the most prevalent risk behaviors. And then you now look at the risk behaviors of those that are positive, and it gives you the different figures and the numbers for those that are positive. If you want to do your campaign or your elimination strategy or awareness, then this can give you information about what risk behavior is more prevalent amongst those that are positive, or the new positive for that year. Then you can see the other risk behavior of those that tested positive also, and see what is most prevalent. You can export all of this information in tables where the figures are already there. And then you look at prevention services, where you can get the number of MSM that received a defined package of prevention services, the number of sex workers that received a defined package, the number of transgender male who received that package. You can get the number of clients on PrEP, on PEP, on ART, and all of those information you usually report. You have them on tables, you can export and submit. And the OECS summary report sheet is here, where this is exactly that form, only that the system pulls out the figures and fills them in for you, and all you need to do is just export and submit. So you can go through that on your system to see the category, the variables, and make sure they're up to date with the current reporting indicators that you have. So we have the number of ANC attendees, gives us the total number. The ANC attendees who had syphilis, HIV, or hepatitis screening, it gives the different screenings that they had. Those who has a positive test result, those who had negative result, the number of clients initiating ART, the male, female, and then it is now disaggregated by those less than 15 years old and those that are 15 years and above. You get the number of clients on ART 12 months after initiation, total number of clients on ART, and the number of people living with HIV in care, and this doesn't include exposed infants. Number of people living with HIV that are all alive. We have number of people living with HIV that initiated ART with CD4 count of less than 200. We'll go to the next tab. We have number of adults and children that has at least one viral load test conducted. Number of adults and children that initiated ART that had a baseline viral load conducted. The number of adults and children that initiated ART with an undetectable viral load at 12 months. Total number of male that have sex with males that are screened, total number of transgender that are screened, total number of sex workers that are screened, and total number of MSM that tested positive for HIV, transgender that tested positive for HIV, sex workers that tested positive for HIV, and the number of MSM who have received a defined package of HIV prevention services. We get the number of transgender who have received a defined package of HIV prevention services, number of sex workers who received this package, total number of MSM that received an HIV test and know their result, number of sex workers that receive an HIV test and know their result. The total number of transgender that receive an HIV test and know their result, the number of reported cases of TB, the TB notified cases that are bacteriologically confirmed plus clinically diagnosed, both the new and the relapsed cases, the number of TB cases, all forms, the number of TB cases, and number of TB patients who had an HIV test recorded. We get the number of HIV positive TB patients who had an HIV test recorded, the number of HIV positive TB patients given ART during TB treatment, number of HIV positive patients who were screened for TB and in HIV care setting, and the number of HIV positive patients starting TPT or IPT during the reporting period. So these are the reporting indicators from that sheet, and the system gives you. So assuming you have your records complete on the system, you can trust what information you get out of this and just export this. Yes, I'm Dr. Peters.
Hi, good morning.
Good morning.
Is there a particular reason why we use the age groups 15, more than 15, less than 15, and in other cases, 25.
I am not even sure, because that is exactly how the reporting indicators on the sheet states. So I just did it exactly like that. But I'm not sure exactly why they put the different age groups that way. Some are 15, some are 25 plus.
Okay.
Yeah, so Dr. Peters, normally
Yes.
Organizations who international and regional organizations who lend support do have indicators, and the indicators usually, just like how our census is done, gives you an age interval. So you find some organizations use 5 years or 4 years and so on. If you look at our census gives it to you in every 5 years. So it will be 20 to 25, 26 to 30, and so on. So it's just a way of reporting, so you can get numbers. Below 16, obviously, 15 and above, again, we're talking about the age of consent and stuff, so you look at that also, and what is considered a minor for different organizations, so they do it that way. But it's just most of the reporting tools do have an age interval.
Okay.
Yeah, thank you, Lester. I think that might just be the reason for it, and that makes a lot of sense. All right, so we have looked at the risk behaviors and all the reports. Again, when you want to get your OECS summary sheet, it is labeled Behavioral Reports, Prevention, OECS Commission, M&E Summary Report. So that's one report. Now, when you go to the commitments to the 1990 target and look at the people living with HIV, you select the reporting year. And then we now look at testing volume and look at the people screened, number of ASN screening and all of that. You look at the different categories of those screened: exposed infants, ANC, and the general, excluding the antenatal clinic. And then you look at the positivity based on the different categories, whether they're exposed infants, antenatal clients, or the general population excluding antenatal clients. Then you want to look at the ratio of positives by the different categories. You look at how many antenatal clients constitutes the percentage of the new positives for the reporting year, and you want to look at the HIV care referrals and look at the number of exposed infants that are referred for care and management, the number of adolescent pediatric adults referral that has happened in that reporting year. Then you look at another OECS summary sheet that we have that looks at the different indicators for the different line of treatment. So we have category 1 to 4 years on first line, and this disaggregates by male and female by their biological sex. So we have the age group 1 to 4 years, we have 10 to 14, 15 to 19, and this just looks at those on first line, those on second line, those that are on ART and are died while on ART, those on first line, second line for the different age group, and the same thing all through until we get to the last age group. Now, assuming you record all your clinical information on the system, the figures will be filled in. And then we have, after all of the different age group, we now look at the number of clients that are lost. So number of patients on first line that are lost to follow up. We get the number of patients on second line that are lost to follow up also, the number of patients that are lost to follow up. Then we have the clients on ART, number of children less than 15 on first line, less than 15 on second line. And then we look at number of adults greater than 15 on first line and number of adults greater than 15 on second line. Then we look at the summary of all of the clients on ART and the total death of the clients on ART. We also look at people that are on first line, male, female, less than 1 year, and then we look at those that switch line of medication, number of pediatric that switch from first line to second line, and number of adults that switch from first line to second line. Then we have the antenatal reporting, where we look at the EMTCT report, assuming we have records for perinatal syphilis recorded on the system. You will get that. This also comes from the sheet also for the EMTCT reporting sheet. It will give you the child's unique ID, the mother's non-trip results and the titer, the trip test results and the LMP of pregnancy, the mother's treatment, the outcome of that treatment, the date of delivery of the child, the child screening and titer, the treatment details, the outcome, the comments. So you find those data populated on this table, assuming we have records for perinatal syphilis entered on the system. Then we also have that for hepatitis monitoring that collects those information also, where you get all of the mother's first prenatal visit, the treatment that was received, if the mother was confirmed prior to delivery, if the mother was confirmed after delivery, the hepatitis B surface antigen result and the date of that result, the infant's surface antigen results and the date, the symptoms of the infant's diagnosis and the infant's vaccinations. We get also that of the HIV positive summary for the babies. Now we have the mode of transmission, the date of viral load, the treatment for all of the babies, exposed infants who later turned positive here. Okay, and then for pharmacy reporting, we get the OECS summary sheet for pharmacy also, and this also puts in the figures of the medication in stock, the stock here and the year of expiry of all of the medications will be there, and then the drug dispense, what medications were dispensed for the different drugs, number of clients that has every particular medication. So because we have limited information here from all our trials and practice and training, we only get what we put into the system. Now we also have the drug dispense sheet, where it just gives you the prescription number, the unique ID of the client, the type of client, if it's a client's HIV client in care, or a client on PrEP or PEP, or just a client not for HIV treatment but for any other treatment, the sex, the date of birth, the prescribing physician, the dispensing pharmacy, the name of the drug, the amount supplied, and the date dispensed. And so this gives that record. Now these are the reports that are generated automatically from the system. Does anyone have a question before I look at the other part?
Mildred?
Yes.
Question, you were saying that it's easier to upload it to spreadsheet. How exactly is that done?
Okay, so the spreadsheet thing only works for screenings. You don't, apart from screenings, like you take the. Okay, let's do some examples about the spreadsheet after this, and then we'll come back to the reports to see how that adds to the report. So the major thing we want to look at now to see how we get this report in real time is that we know the number of new clients that is created is 118. So let's add more clients to the system. I'm going to come to my downloads. Okay, so we have this spreadsheet that is filled in. I will change the unique ID. Okay, so we have the spreadsheet. Now, this spreadsheet has different columns that must not be edited. When you receive the spreadsheet from your supervisor, because only the supervisor has access to download the spreadsheet. And the reason for that design choice is because sometimes we change the configuration of the system, add new things, subtract things from it, edit things that were there previously. Now, the first time this system is used, the information on the spreadsheet, or the information that populates the drop-down menu of the spreadsheet, is already preset with different values on the different sheets you find here. Now, assuming the configuration changes on the system, that configuration needs to be updated on this sheet that feeds the drop-down menu here. And so because it's going to be chaotic and will lead to a lot of errors, we gave it that single control where only the supervisor will be intensely trained and understands how to make sure the spreadsheet is up to date with the system configuration, and then shares that up-to-date spreadsheet. We looked at that in one of the trainings in module 2, I think, and so, or module 3. So if you go to those recordings, you'll see how a supervisor can set this. So once you receive it as a user, the first sheet, client batch upload sheet, is the sheet that you should focus on. On this sheet, the supervisor will make a rule on how many rows of information you want on each sheet. While it can take several rows, you want to limit errors by maybe limiting it to 20, 30, 40, 50, not having thousands on one sheet. So let's say we already have 20. I need the next one. I'll put 21, and I want to put a unique ID, KKK143. And I'll select the name of a country, let's say, or the name of a testing site. I'll say infectious disease clinic. The facility type, let me say infectious disease clinic. The first name, let's give the first name here Hannah. Hannah doesn't have a middle name, and the last name of Hannah is, let's say, Hosea. The mother's maiden name is not known, we'll put unknown. And then Hannah is biological sex is female. The date of birth of Hannah, let's say, is 23rd day of November. And then the year is, let's say it is 1990. Hannah's country of birth, let's say it's Argentina, and Hannah lives in let's say Hannah lives in Dominica, for instance. Now the address of Hannah, let's say Elimination Street. And the health district, you select from a drop-down menu. The parish, you select there. And then the marital status for Hannah, let's say Hannah is, let's say, married. Hannah's occupation is self-employed. Sexual orientation, let's say heterosexual. Hannah identifies as a female. Hannah is, let's say, Hannah is, let's say, Caribbean Amerindian. Educational level, highest level, let's say college. Hannah's number of sexual partner, let's say, is 1. Hannah doesn't have oral sex, has vaginal sex, and let's say also has anal sex. Now Hannah is not diabetic, we'll say no. Hannah doesn't have high blood pressure. Alcoholism, let's say no. Malnutrition, let's say yes. Renal disease, let's say no. Lymphoma, let's say no. Chronic lung disease, no. Test modality, let's say oblique. Then type of test, we want to do rapid test, and let's say test kit 1 is determined. And let's say this was non-reactive. And let's say the result date is 24th October, and then the year is 2024. Now let's delete this. There's no second test. Let's have the risk behaviors. Had sex with males in the last 12 months, with females, let's say over 12 months ago, with persons of known HIV positive status, we'll say never. With sex workers, let's say never. Exchange drugs for material gain. Now take note that at this part, test 2, if let's say you are doing a syphilis rapid test, you can select this and fill in the value. It doesn't have to be HIV or any other screenings you are recording here. Or you have a second rapid test and you have Unigo, you fill it here. So let's say this is still non-reactive too. So you can, if you have 2 tests, you fill in both. If you have 1, you can fill in 1. If you're also doing a syphilis rapid test, you fill it in also there, and put the result and then the date. So I'll just fill this in just for example purpose. And then the risk behaviors, exchange sex for drugs or material gain. Now take note that if you edit any of the column headings or any definitions that this has, or the ones that have a drop-down menu, you select something different or you put in your own value without using the values in the drop-down menu, the system will reject this sheet. So let's say shared measles over 12 months ago, crack cocaine or other illicit drug use, let's say never. Had sex under the influence of drugs or alcohol, let's say over 12 months ago. Had sex with multiple partners, let's say over 12 months ago. Had perinatal exposure to HIV, let's say never. Receive a transfusion of blood or blood products or clotting factor, let's say never. Occupational exposure, we'll say never. Being a victim of sexual assault, let's say never. Receive a transplant, we'll say never. Confirmed diagnosis of STI at the time of testing, we'll say never. Confirmed diagnosis of TB at the time of testing. Had contact with confirmed TB. Being previously diagnosed with HIV. And the condom use, let's say, just say rarely. Incarcerated or history of incarceration, never. Homeless or history of homelessness, we'll say never. Sex worker, or history, we'll say about 12 months ago. Sex with transgender female, let's say never. Okay, so you finish filling in that row of information. You can do the next number and the next row until you get to the maximum number that your supervisor wants for each sheet. Now take note that if this is a client that doesn't have an account on the system already, you enter the unique ID there. If this is a client that already has an account on the system, you enter the unique ID that the client has on the system. So what the system does is when you upload this sheet, it checks for that unique ID. If it already exists, it updates all of this record. If it doesn't exist, it creates that account. So you skip all of the create account, request release, and then go through the tab to collect information. This handles everything. And then when this is done, you cannot upload an Excel file to the system. Now, because Excels are like binary files, and all of the information about the worksheets, the style, and everything is saved, and the system cannot accept anything that is not a text file. And so because of this, we need plain text. And for us to get plain text, we convert it from an Excel sheet to a CSV file. We come to File, we come to Save As, and then we come here and select CSV UTF-8. Just make sure that your label is CSV UTF-8, comma delimited here. And then when you save this, let's say at the location, you click OK because you're only saving your active sheet, which is the first sheet, client batch upload. OK, now this is saved. Now you email that to your supervisor, either has the Excel sheet and your supervisor is going to convert it to CSV, or you send a CSV sheet. The supervisor has administration permissions. Now I'll log in as that supervisor. And I'll click here. So the supervisor will come here, click on upload offline data, upload screening template, and choose that file that we just done here, and then click on upload. Just make sure the extension is .csv. It will not accept anything that is not a CSV file, and we upload. Now the supervisor has to make sure all you are seeing are confirmation in blue banner, and you scroll to the end to make sure down to the last everything is in blue banner. If it is not in a blue banner, just screenshot what error you have and forward it to any of your IT support, And if it's still under this warranty period of the system, you can forward the email to me to see. So now we are happy. Everything is well uploaded. We have 21 new records added. What we had previously was 118. So when we come here, let's log out. And we come to the surveillance part now. We can come to see registered client report. We select 2024. What we had before was 118, and now we have new client related is 139. So we added I think 21 more just now on the spreadsheet, and then it gives you us 139. So when you want to validate the accuracy of the surveillance reporting, let's say it's always good to validate the accuracy of these figures, right? Because sometimes we might think things are perfect, but the more eyes that goes through it, you might pick out one error or something to be corrected out of it. Now this gives you the figure as we expected to have, because we added 21 new records here, and automatically the system recalculates that report for 2024. So the system does not save any point in time reports. Anytime you select 2024, it gives you that record as it is on the system at the very second you selected it. If new records are entered in the next 1 minute, this is going to change the next time you refresh this page. Okay? Does anyone have any question or anything? So did I answer your question, the person who wanted to look at the spreadsheet? Is it clearer?
Yes, Manager, it is.
Okay.
It's just practice and make it even,
Yes.
clearer, yeah.
Yeah, so now why we have the spreadsheet for only screenings, if any country wants to have a spreadsheet for batch upload of antenatal, I don't know if time will permit, we can add that, because if it's easier, if you find out it is easier for you to use a spreadsheet. I know some people have said the spreadsheet looks easier than navigating all the different pages of the system. And then once you have positives on the spreadsheet and it's uploaded, the next thing you want to come onto here now is to log in as a user assigned. The screenings and management rule, and then you come to referrals. Now let's go back to that spreadsheet and let's see the unique ID of those that are positive. So we have screening result of that is reactive for the first client here, and that's the unique ID. So you take this unique ID. So assuming the supervisor uploads this thing as soon as possible after you send the sheet, and supervisors will have to make a decision whether once they receive this sheet within 24 hours they just upload everything, just so that you can continue on the system and do your referrals. Now this person is positive, your work is not done yet. The unique ID you have on your spreadsheet, when you come back to the system, you can now log in as a user assigned screenings and management role, and if you have the referrals permission, you are referring new HIV case for care registration and management, and then we put in the date and then that unique ID, and then we category here is, let's say, adult, and you refer, and referral is successful. So now this person now can be registered into care. When we come to HIV care referrals, we will find that client that was just referred, and then we can now register this client into care. So all the clinical management from referral to clinical management will continue on the system. Now, if the client is antenatal, then you can't use that sheet for an antenatal client, because it's going to be recording against the general population and will not tag that screening against pregnancy or look at the gestation age when the screening was done. There has to be a different, you have to use the system for antenatal clinics. So if you have an antenatal clinic, you have to use the system to do all of the registrations and creation for antenatal. Okay. Anyone with any question before we move on? So now back to the surveillance reports. Let's look at how these reports are actually calculated from the data that we have entered. I believe if you have that understanding, you'll be able to know where this is coming from. And in the event you want to re-verify or want to get the raw information or want to use the raw figures, you understand how it is calculated. Now, for this registered client report that we looked at, we have the total number of clients whose accounts are created on the system. Now, there is no magic that the system will know if one person has two different identities on the system. So every time you create an account, the system counts that as a new person. So if you have one person having three different accounts with three different unique ID, the system sees them as three different people. There is no how the system can know, and there's no technology that can detect if one person is using 10 identities. Why it is very technical at this point is that there are people who might be two different people, and a lot of their characteristics are exactly the same. So we can't make the system flag and say these people are similar and merge their accounts. So when you get new registration summary, it is looking at the uniqueness of the accounts that you have created, the number of unique IDs that we entered. It will not tell you if one person has 5 accounts. So that one person is counted 5 times. So that's the reason you have to make sure that when the clients already have an account, if they forget their unique ID, you need to retrieve it rather than create a new account. When we look at the sex ratio of registration, we're talking about the biological sex, not the gender identity or anything related to the sexual behaviors of the client. It just means what the client was assigned to when they were born. And for reporting purposes, there are 3 different sex that are recognized: the male, the female, and the intersex. So when a client says they are female, and you know that they are transgender and their biological sex is male, the question is asking about their biological sex and not what they identify as. There is another form that collects information about their gender identity. So when you see gender or sex, we're talking about what they were born as, and when we get to the gender identity, we're now talking about what they now identify as. In the event they identify as something not on your drop-down menu, then the supervisor has to add that from the configuration part to add that to the drop-down menu of the list of gender identities. So this only talks about the biological sex. Then the new months of the different months where clients were registered on the system. So this one, you can use it to know the number of new clients that walked into the site in a particular month and all that. Then we can have, so when you want to compare those whose biological sex are male and the gender identity are male, those whose biological sex are female, gender identity female, those whose biological sex are female and identify as male, and those whose biological sex are male, identify as female, you get the number. And then all of this that we've seen has a table where those figures are calculated for export. So this is how the system picks that figure out. For the HIV screenings reports, when we get new screening summary, it doesn't just select if a particular client screens in, let's say 5 times in 1 year. Let's say there are people who, maybe because of their risks, decide to screen every time they change sexual partner, and they end up screening 5 times in 1 year. This takes the unique number of persons that were screened. So we get like the total number of screenings and the total number of persons that are screened. So when you see the total number of people that are screened, this does not mean the number of screenings that were done. We would have done 500 screenings, but those 500 screenings were for 133 people. I don't know if it makes sense.
Yes.
Okay.
It's right.
Yes.
It makes sense, but if you also want to know how many tests were done, for example, for accountability, so you want to know how many tests were done, not the number of persons screened, because we already have that information and it's very much needed. But if the unit does 500 tests a year, is it documented somewhere? Is it captured somewhere?
Yes. So that's part. Okay, so let's go there. So the supervisor, we talked about the supervisor that is assigned the administration role. I'll log in there now. This supervisor has this part where we say supervision, and you want to get the total number of HIV screenings that were recorded, not the number of persons. This is where this is, and it shows us 136. It does not matter how many times a particular person is screened, it just gives the total number of screenings that were recorded. So these are the information the supervisor has for supervision purpose. On the other part of the system, it's when it gives you the number of persons screened, and there's a part of the table where it now shows the HIV screenings done, the positives from the screenings, number of positives from the screenings, and the number of persons that were positive. This is where the supervisor can actually get the total number of screenings done and how many screenings were done at the different sites of screenings. So they can filter the sites to say this for this site, testing site, and see the total number here that are from that testing site, and then they'll see that for another testing site and the type of test used and all of this information. These tables are exportable also. Then the supervisor can also get the same thing for TB and syphilis and any other screenings that were recorded on the system. That same supervisor can get the information about all of the number of condoms that were given and the number of test kits that were given out. Because the supervisor uses this information more often and doesn't have to depend on surveillance, it is on the supervisor's page for when we see supervision. And so the supervisor can also get all of those screenings by different sites and go to the file to see if all of the information are captured from here too. So there are information that the supervisor can access and is on the supervisor's page so that it can especially frequently use information so that the supervisor do not have to depend on the surveillance unit. And then those that are from the reporting indicator sheets are all on the surveillance dashboard. Now, does it answer your question?
Yes, it does. Thanks.
So on the manual, it states out all of the different reports that are captured. So once you're not sure if a particular report is automatically reported by the system, you can go to, let me get the page number for you on the manual. And I mean, this will change in the coming weeks where the manual will be updated to capture all of the new things that we have done. So you can start from page, I think it starts from page 130, thereabouts. Yeah, from page 130 of the manual, it breaks down all of the reports that the system generates automatically and the figures you can get. So let's continue to understand how the different parts are defined. So when we get the pregnant client, now because things are changing, right? And I think someone mentioned that when we do instead of having an ELISA test to confirm positive, when you use determine to do the first test, the person is reactive. You use Unigo, the person is reactive, then the person is positive, right? So before now, the system, I think that's what is mostly on your live systems until I make this batch of updates. The system will calculate reactives different from positives. So it looks at reactive as the HIV rapid test and then the positive as those ELISA-based tests. But now, when anybody has 2 reactive or the 2 test kits, it just counts it together as the positives. And so that is the definition it uses. I will put the definition somewhere above so that whoever is exporting the record knows how it is defined. And if the definition goes contrary to the information you need, then you can just export the record to generate whatever you want to generate out of it. Okay, so we have this total number of people, unique people that are screened, and the ratio, it just looks at the percentage of each of the different biological sex that is screened, and then we look at the ratio again for each of the biological sex that is positive. Okay, so we'll see that the percentage of the ratio that's screened and the percentage of the positives, which one makes. And for those who do research or write reports, you can now see that if you are screening more, let's say you're screening more males and you're getting less male positive, you're screening less female and getting more positive, it can be an information not to say like, are we having more positives because there are more positive, or we're having more positive because there is more testing? So things like that, those kind of analysis. So you actually accurately be able to accurately give informed decision that we are actually not having more cases, we're just having more screenings, and so we're getting more cases from the screenings. And if your screening is less or the same and you're getting more positive, now this can give you a different kind of information that maybe the cases are really rising more than it is. And then the trends in the screening every year, if we get to January 2025, 2015 will be out, 2025 will be here. And it just gives you the most recent 10 years of all of the screenings and all of the positives trend. Then per month just takes the months of the screenings, that's when the HIV screening was done, and just calculate the figures. And you see the bar is always color coded with the different biological sex of the people that are screened, and it's interactive, so when you hover around it, it gives you the figure of each of the gender here. So if you want to report by gender, you get the figures. Now, by age group and sex, the age groups are 0 to 4, 5 to 9. These age groups are done according to how the age groups of the census population in the countries are. Now, for all the countries, thankfully, the age groups for census population was 0 to 4, 5 to 9, 10 to 14. And so there is no way we can do by age group and sex outside of the ranges that the census population is, because when we get to per 100,000 population, these things become chaotic because we are using a different age group than is captured by the census population of the country. Okay. So the new positive summary. So if you have a different age group, go back here, and maybe they want you to get 0 to 15, you just use this and calculate how many people are here up until here. So this is where manual work will start if you just want to report a particular age range that is not the same. Let's say you want to get everybody 15 to 29, for instance. You are taking all these figures, this and this, and you're stopping here. So this is the easiest way you can make that calculation yourself. Then all of these things were just the total number of all of the screenings, and then you begin to have that summary by the results of the screenings. And again, it takes the unique result. So if somebody decides to do a confirmatory test 10 times, it only picks out one of the results of that person, the most recent of all of it. So if you do 10 times, all 10 are positive within the same reporting year, it is taking that result once for the number of positives. By age group and sex, the same thing. If a particular person does it 10 times, regardless of what testing site within the country, and maybe some people just want to keep confirming and reconfirming, the number of positives is going to still be unique and not going to calculate that somebody was positive repeatedly test 10 times and then the figure increased by 10. No, it looks at the reporting year and how many times that person was confirmed positive for that year and takes just one of it. Okay, and then by test modality, I think this is a UNH reporting where where there are different test modalities that are set on the system, and it just gives a number of people that are screened by the different modalities, if it is via outreach, via PMTCT screenings, or emergency room. I don't know exactly what this information is or the extent to which this information is used, but I know it gives information at where the testing drive is more effective. Okay, so this is how these are calculated, and so you have knowledge of how the figures are extracted. If what you want, or the total you want, or the summary you want, the calculation method is not what the system uses, then you want to just export your figures and use that to calculate exactly what you want to get if it's not on the system. On the system, this is how the calculation was done. So you find the details on how these calculations were done on the manual, so it informs you to know what you want to use it for. So the definition is exactly the same for syphilis and tuberculosis screening. And then for the behavioral reports that we have here, the system does not take what the client says. So you can't ask the client, are you part of key population, or are you MSM, are you a transgender, all of those things. It doesn't use that information. It uses the information from the behavioral risks that we calculated. The number of male that says they have sex with males in that reporting year, in the behavioral risks that we selected. And the system now does the classification to say these people's biological sex are male, they say they have sex with male. These people are transgender male. According to their male, they identify as female, and they, based on what they feel, they are transgender male or transgender female. The system counts that figure in that category. This person is male and decides that their sexual orientation is homosexual, and the system calculates that. So when they say homosexual, it now looks at the behavioral information fix, where you see had sex with males and say in the last 12 months, and females never, and the person is homosexual by the classification of the system, and then bisexual too. So the way the system classifies this is based on the combination of the biological sex, the gender identity, the sexual orientation, and the behavioral information of the client. So somebody might be a male that only has sex with male, but identifies as and does not agree that they are part of any key population or whatever. It doesn't matter. The system just classifies this based on their different risk behaviors and their biological sex. So it takes all of these information and put them there. Other information it takes from what the client says is like number of sexual partners that the client say they have, and all of those different, if they're sex workers, if they've been incarcerated, or all of that. Now, you know that not everything the client says is actually what it is. People say what they're comfortable saying. And so when you take these risk behaviors of clients here, the ones that are classified by the system are the ones that deals particularly with key population, these ones. The ones that are done based on what the client says, like number of sexual partners, crack cocaine. There are people who have one sexual partner, and for the purpose of whatever ego or pride will tell you they have 2 to 4. There are people who have 5 sexual partner, and for the sake of looking decent will tell you they have 2, or they have 1, or they don't even have at all. So this is just based on what the client says. It's not based on whether it's actually true or not true. Okay. So the risk behaviors is also categorized by those that are positive. So when you fill in the behavioral information or the risk behaviors of a client, when you collect information before the screening, the system looks at where the client is classified as on the system based on the algorithm, and now also looks at the HIV screening results of the client. And if that client is positive, put them in the category as people that belong to this particular category and are also positive. And I'll use that figure to create your chart. Okay, and it does that for other kind of risk behaviors that were reported. Now, all of those things are available to be exported as raw figures for you to do whatever you want to do. There are different formats of exports. You can export as CSV, as Excel, as a PDF file, or you can print it out if you want. Then we have the prevention services also. Now, there are reporting indicators that we're given that says that you want to know the number of people in each category that had different kind of prevention services. And those indicators were converted to an algorithm that checks the people who the system has put in the category, in each of the different categories, and then looks at how many condoms were given to this client, assuming it is recorded on the system. So this just shows us how the completeness of information you collect about the client is very important. If not, you will have some records on the system, you have some you have to calculate manually. And I keep saying this, there's just so much noise about data, but there's not too much noise about quality and usable data. And it's better for you to reduce your testing volume per day. And if you screen 5 people in a day and have 5 data, it is more useful. The data is more useful than when you screen 100 people and you have incomplete information. So it's just better to know that this takes time and it has to be done well. So when we walk into a lot of pharmacies, you'll see that there is a sign on the wall saying it takes at least 15 minutes for the pharmacist to prepare your prescription. So you have to wait. There's no room for error. So they take their time and make sure everything is entered correctly. The same thing with all of this information. When we're looking for data, it just has to be entered complete and correctly. Once the clients feel that they don't have the time and they know in advance that you will spend 30 minutes when you come for the screening, it begins to limit that panic that this is wasting time. Let's just do and move. And at the end of the day, you do so much work that doesn't even give you the results that you want. So that's the reason for that. So we'll have that in mind when you fill your information. You want to make it as complete as possible. What is worth doing is worth doing well. And once you have the information entered into the system, every time you're asked for a report, it's just so easy. And with the API, you might not even be asked for the reports because they can make direct calls to the system and get the figures on the system. So when we do the API training from November 11th, you will see how other partners can just get information, make API calls to get these surveillance reports directly on their dashboard without having to call, assuming your records are up to date. Okay. So once you fill in the clinical management notes of a client and you have the category is a positive client in clear, or the category is for the islands doing PrEP and PEP. The category of the client is not a positive client but on PrEP, and this is filled in on the prescription. The pharmacist can select that on the drop-down menu of category of clients, and that will now report here. If those information are not entered, what will be seen is the zeros. Not that it's not done, but because the record was not entered. It's whatever you put in the system that the system uses to give you back the figures. Does anyone have any question or comment? Okay, so for the OECS M&E summary sheet, it's exactly the same thing. This number of ANC attendees just takes the unique number of people who were pregnant or who are still pregnant in that reporting year. So it's select 2024, even if the person has had the baby, but the person was pregnant this year, it gives the total number of people who were registered for antenatal for that reporting year. And then when they were registered for antenatal, those who were screened for syphilis or HIV or hepatitis, it is going to take the number of those who were screened as part of the antenatal service. And it's going to give, so this again does not take the number of screenings. Even if it's done 10 times, it just takes one unique number that this person was screened. Yes, it doesn't matter how many times you report that as one. Then the number of the antenatal clients that had the positive test results for both HIV, syphilis, and hepatitis, it takes again one of it. Even if there were 10 results that are positive for that client for that year, it just counts it as one. Then the same thing for the negative. Now, there's a reason why there's a positive and there's a negative result here. Normally, when you have the total number of those screened and you have positive, you know automatically the rest might be negative. But there are some times that we have awaiting results, and sometimes that it is not, the result is inconclusive yet, and that's the reason for these different figures. So that when you see this, sometimes the total is not going to match this total here, and it's because of all of that different reasons. Then when you have number of clients initiating arts, it just looks at for that year 2024 how many people were marked as the treatment plan was marked as start new treatment, and those people, what is their biological sex, and from those people again, what is their year of birth compared to the reporting year that you selected. Even if this were 2030 and we are getting a report, it is going to not use 2030, but it's going to use the year that you selected here. So everything will be based on the reporting year you selected. So if the person's year of birth is a particular year, it is subtracting that from the year you selected, not from your current year. So if this was records from 2019, it will be selecting their year of birth from 2019 and not from our current year. Everything is based on your reporting year. Then it now looks at those who were on ART, and if the prescription is given every 3 months, that means the system needs that prescription to have been written and dispensed every quarter. If you have a prescription in January and the duration is 3 months and it was dispensed on the system of 3 months, was recorded, and there is no prescription or dispense recorded on the system from the rest of the year after that one in January, then it now counts the person as the person is no longer on ART. But first of all, it counts the person as a client on ART 12 months after initiation of the ART. First of all, it looks at when the client was started ART, which is the 1st January, and then looks at the end of the year, December, or when whatever month we are in, it calculates 12 months back, and see if these clients have a consistent prescription that matches 12 months, or the client is not part of this number. Okay? Then it looks at the total number of clients that are on ART. So if a client has 10 prescriptions in 1 year, it doesn't count it 10 times. It just takes the unique clients. Like you were prescribed ART in January 2024, you are counted once. Even if you are prescribed in February, March, and April, you counted once, you're on ART on this year. Okay? So now I know you get the idea of how these calculations are done, right? Anybody? Does it make sense how it's calculated? Does anyone have any queries or questions about it?
Mildred, I'm just wondering, you say if the person collect medication more than 1 time a year, it doesn't matter. I'm not sure if I got you right.
Yes, it doesn't matter because it's just looking at number of clients on art. Total number of clients on art, right? And so it calculates the unique clients, not the number of arts that we're giving out. So if like the person had the prescription 10 times in 1 year, in the reporting year, that client is counted once because it's just the number of the clients we want who are on art, not the number of times the client was prescribed art.
Okay.
I don't know if it makes sense.
So when you're looking at loss then, because if the person doesn't collect medication for 3 months, they are considered as being lost. So
yes.
If you're looking at one time, how does that account for loss?
Okay, so now this looks at the total number of clients on art, but now I want to look at the loss now. Sorry. We have the loss at the other summary sheets. Let's see that. Okay, now if you want to see those who are, I think it's the other pharmacy sheets, we get the loss. Hold on. No, not this one. Well, let's go back there and see. So there is a part, and I want to show you where it says the number of clients that are on art that are lost to follow up. We saw that earlier. It's on a different sheet. Yes, so these are the clients that are lost. So number of patients on first line that are lost to follow up. How this is calculated is, let's say for instance, the client was prescribed art in January, right? And the drug, the quantity or the duration was for 3 months. And then the system has no record of any prescription or dispense for that client for the year anymore. Then that client is already lost lost to follow-up. If the client was prescribed in January, there's no records of any prescription or dispense, and maybe sometime in November, December, the client was prescribed again, there's a record, that client is not lost. And that's how the system calculates it. I don't know if you understand.
I find it's just a little bit confusing to me in the sense that you have to do this art report every 3 months.
Okay.
And if a person do not collect treatment for 3 months, they are being considered as lost. So if I have to give you a report from the information I collected, I might say, oh, I have 2 losses. Or how much losses. But when you look at this now, if the information is where you can get it from this, you might say my figures contradicting what you have. So I was just looking at it that way, because if the person only collect once per year, and the person, how much of the time, it doesn't really matter. And then you are saying to me, if the person does not collect for 3 months, they are lost. You know, it's a little bit, if you follow what I'm trying to say.
Yeah, I follow what you're saying, but the way the system does it, like if a duration of drug is 3 months and they gave you 3 months, it was dispensed for 3 months. After 3 months, the system does not see any other records. So let's say prescription was given in January and the system will expect to see another prescription between March and April or another dispense. Now, by the time that for the duration and the quantity of medication given out to the client, based on what was recorded on the system, is already done, and it's expected that this client had 90 tablets, it's over 90 days, there's supposed to be a new prescription, a new dispense recorded, there's nothing recorded for that month, the next month there's still nothing recorded for that client, then this client is already lost to follow up as at that time of reporting. But if you're now looking at the whole year for the clients, you're talking about every 3 months. But if you're looking at the whole year for the clients, and that same client did not take another medications from April to November, and the system sees the client as lost, and you want to get this report again in November, and it happens that the client shows up in the clinic and was prescribed and was dispensed, then that calculation at November now changes from lost. The client's number is taken out of the lost to follow up. I don't know if you understand.
Yes, please.
Yeah. So it's similar to what you're saying you do on paper. It's just that the system calculates it's loss. It puts a client in a loss category and puts the clients back in category of clients that are on art, depending on if that client was lost and now came back. Or let's say, for instance, someone collected for 30, 60 days, traveled out from the beginning of the year, came back towards the end of the year, maybe was collecting medication somewhere else, did not report that, did not take extra from where they are, and then just comes back in November. If you get your report in October, the client is lost. If you get your report in November, that client is removed from the list of lost because there was now a new prescription and a new dispense for the client. Okay.
Mildred, that is for calculating loss to follow up for the year.
Yeah.
Is there any part of the system that calculates it from one reporting period to the next in terms of the 3 months?
No, this just does per year.
Just a year.
Yeah, this does per year, not per month. Until now, no one told me that reporting for this is every 3 months. So it looks at the whole year. So which makes it now difficult because the system doesn't store. Except let me write it down. Except I do it that way so you can see it at point in time. I can add that. Let's see, point in time. So what this does is for the whole year. So assuming you need this report every 3 months, and let's say you report at the end of every quarter. At the end of March, you will see the number of clients, or maybe April, you'll see the number of clients that are lost to follow up, who there is no dispense, there is no prescription, or the client did not come back to the clinic here. If that client happens to just have a 1 month, 2 months delay and comes back sometime in July or so, you come back to this report, this is updated. It doesn't save what you have had before as at March. You would have exported it by that time, at that time to see it. But now you're saying you want to have it per quarter, so you can just say clients lost in first quarter, second quarter, third quarter, so you can have that saved on the system. So every time you get this report for 2024, it breaks everything down at different periods. Is that what you're saying, Dr. Nisbet?
Yes. I'm talking to the monitoring evaluation officer, and we report every 3 months. So.
All right, so I will update this part of the system. So when you see the update on your system, sometime before the end of next week, you will see the different points in time. But the sheet I got when I was creating this is just number of first line loss to follow up in a reporting year, and nobody told me about the point in time. So that's why that was not done that way. Okay, so this will be updated.
But I don't know, the other countries can give an input.
Okay.
Or the monitoring evaluation officer can speak, but I think that is how it's done.
Okay. Anyone with any input, suggestion? I mean, anything you've seen so far, if it's not the way it's supposed to be, anything can be changed at this point before I make a final, so you can actually go through critically and make your comments and suggestions or whatever you want change or recalculated in a different way. After this period of updates, it will no longer be possible, so it's better you do it now. And you can also log onto your live system and go through them critically and write out maybe what you don't see and you want to see, maybe something that is calculated somehow and you want it a different way. If I get that by this weekend, I will definitely be able to add that before I do the batch update of all of your systems. But if I don't get that early and this phase of the project passes and I submit a report, I won't be able to change that anymore.
Mildred, I'm just wondering now that you talk about life system. I don't know. I just can't get into my lawn system to practice at all. Is it that? Do you know if it is that it is not activated or whatever? I don't know. I'm using our life system is okay. The same password and Gmail, email address is working. Everything is working for the life system, but I just can't get onto the lawn system.
So I'm not sure if they activated it after it was migrated. It is I think it's learncbs.gov.vc.
Yeah.
Is it LearnCBS or Learn eCBS? Yeah, it's learnecbs.gov.vc. Okay, so for this one, let's see if it was configured. No, it wasn't configured, and the accounts were not put there. So they left this as new, and nothing has been done here. So what will happen is I can give you admin permissions here. I don't know. I think Lisa is in charge of this one, and she can help you configure that. Or if not, if you leave me a WhatsApp message, I can get you started on your Learn system.
Okay. Thank you.
All right. Okay. Does anyone have any questions, comments, query, anything?
So, Mildred, you spoke about the Learn system for the different sites. Apart from the examples that you give us, we can go on our Learn sites to practice?
Yes, your Learn site is just there for endless practice. Just make sure you have an account there. The account on your live system will not reflect on the Learn. They are all independent systems. So the supervisor have to give you an account just the way they gave you on the live to use on the Learn. So the Learn is there, so you don't use the live to make errors and put trial records. You use the Learn to do all of the practice.
Okay.
Yeah, because after the training workshop, this cbs5.mediagroup.com will be discontinued, and so every country has a Learn system. You always have it like learn eCBS.your government domain for each country. So I think for St. Kitts and Nevis it will be learn.ecbs.gov.kn. So that is the site where you can do all your practice, and then for the live sites there is no Learn in front of it. So every country has a Learn site. Okay, so you can go through all of these surveillance reports if you have the time before the weekend. I'll be very grateful if there is anything that is not clear, not calculated as you report it. It should change in a different way. I'll be happy to receive that information. You can email them to me, and maybe keep the commission in copy, and I will make sure I put that update as soon as possible. All right.
Mildred.
Yeah.
Really reporting. I know that we do a quarterly pharmacy report.
Okay.
That would show lost follow-up.
Okay.
But in cases where the patients are quite stable, they've been diagnosed with HIV for years, they're stable, they adherent, viral load is undetectable, the CD4s are doing okay, and they just can't come to clinic every 3 months. So these persons are quite okay and they're quite compliant with being seen every 6 months. And I'm wondering what is in this system to capture them as being compliant instead of being lost follow-up. Is there a possibility that when they're collecting their meds, saying that they're given six months supply, can an advance date, like a 3 months date, be inserted a date in advance of 3 months be inserted to cover the 6 months. I don't know if you get what I'm saying.
Yes, I get what you're saying. So it was because of this same thought that it was created the way it is created now. It does not look at that the person was prescribed in January and by April the person is lost to follow up if there's no prescription. It looks at the duration and the quantity that was dispensed.
Okay.
If that quantity is for 6 months, at the time you are reporting, even if the person does not have a new prescription, the last quantity still covers the client. So the client has no need for new prescription.
Okay.
So the system does not count that client as lost.
Okay, understood. Thanks.
So any other person with questions, queries? We have covered all the agenda for today, except if anyone has question. If there's something you want me to go over again, we still have time. Okay, so in the absence of question, I need to highlight something else also. When you enter your past records, there are certain things you need to take note of. You see all of this information that the system picks. It needs to be filled in on the form that was created for them. Now, if we look at this summary sheet, there is a part of getting information about the viral load and the CD4s. If you don't fill in the initial clinical evaluation and then use the baseline form there to fill in the viral load that was conducted at the time the person was the first viral load test, and then the result was not entered in that form, if you upload the results, while the doctor can look at all the results uploaded under the care card of the client, the system will not be able to read that scanned image of the result. And the reason the system can't do this is because the result formats are different and there are many and they keep changing. And so the system wants you to fill in your viral load, your CD4, test dates and values using the forms. At every clinical management, if there's any updates in CD4 viral load test information, you fill it into the form on the tab that says CD4/viral load and put in the date and the values. That is the only way the system use that to calculate all of these figures that want things about CD4s and viral load. That's the only way the system sees the number of people who have a viral load with a particular value, or CD4s with particular values, and everything that has to do with that. If it's just the scanned copy of the result, then that figure will not be calculated. So while entering records, we need to take note of that. Once there's a form for a particular value, just use that form to enter that value. And the reason there's that form is because the system needs that particular value to generate the report.
If I understand it clearly, somebody was admitted to the clinic.
I can't hear you clearly.
You hearing me now?
Yes.
Okay, I'm asking. I just want to make sure I understand and follow you.
Okay.
Somebody was admitted to the clinic, but at the time that person was admitted, no viral load, no CD4 was done because the lab wasn't doing it for whatever reason. Okay. And then maybe a year after now, the person got a viral load and a CD4 done. What are you saying now? That will be the first CD4 and the first viral load. We had to go back to the initial evaluation and put it in there?
Yeah, if not on the initial evaluation, you put it on the viral load and CD4 form under the care card with the clinical management. So you get that form in two places. You get it on the initial evaluation part, and also when you see the care card of the client, there are several tabs. There's a tab that is labeled CD4 viral load, and it's just a form that just asks for the date and the value of CD4, the date and the value of viral load. You can fill it in there. The system recognizes that this is the first of that result that is entered, and to put it where it needs to put it. and then it will be calculated here. So as long as you use a form for CD4 and viral load, regardless of where it is on the system will pick it up. So either for initial evaluation. Now, why it is there for initial evaluation is you want to, it's just like for a compliance purpose where if it is a requirement that you have CD4 and viral load very close to diagnosis, there's a form there that keeps reminding that we need this value, this person needs to be screened. But in the event it is not possible for first year of many months after the person was registered and the person is already in care, whenever you get the result, you can put it anywhere on the system that has a form for CD4 and viral load.
Thank you.
All right, you're welcome. Any more question or comment? All right, in the absence of that, I will wait to see if I get any email about any changes requested as regards how these things are calculated, and then I'll wait throughout the weekend, and then by next week I will update this before you see all of these changes on your live system. For now, your live system is not at the same point where this system is on, because I have not done the updates. I wanted to do all the updates at once after today's finals, incorporating everybody's changes and comments and queries or any errors that we have noticed throughout the training period. So be patient. Do not use the template on the system until you get an email from me saying that your system has now been updated, and that will happen before the end of next week.
That's the live system?
Yes, your live system. Don't use the template. You can keep using the system as always. The template we just discussed, don't use it on the system yet, and don't use and some of the things that you saw here that you've not seen on your system, I will do all of the updates to your servers, and all of the new changes will reflect. So once that update is done, your supervisors will get an email that the update has been done with all the requested changes, and then you'll be able to, particularly for now, do not use the template on your system until I update that template. That's the Excel sheet I'm talking about.
Okay.
All right. All right, everyone. Thank you so much. And for those in IT here, we meet again for the API trainings by November 11th. And please, any questions, query, you can send an email. You can leave me a WhatsApp message. I'll appreciate before the weekend is over. This week is over. All right.
Okay, thank you.
All right, thank you, everyone.
Thank you.
Okay, bye.
Bye. Have a good day.
Bye-bye.
Yeah, bye.
Have a good day.
Thank you.
Bye. Thank you.
Thanks, my friend. Bye.
Yeah, thanks.